I will give them that. For the classroom.
Yeah.
Hello, amigos.
We're gonna get only one person does this every time. What is she doing? So if I find anything, oh, that's so cute.
Yeah, I'm trying to, but like,
Oh, I'm sorry. Keep going.
the wives
Keep
are
going.
fucking.
Your wife?
Am I going the wives?
Oh, the wife. No, photos. I thought you wanted to.
Yeah.
Yeah, let photos go.
Let me go.
So you're trying to be next to me too. You'll come here, you'll want to.
Good morning. Let's get started. So welcome everyone to our EME seminar series hosted by Department of Biomedical Engineering at Columbia University. My name is Qi Wang and I'm an associate professor here at Columbia. So today we continue to offer this lecture in a hybrid format. The room mic is on.
Try this one. Alexis, can you hear us?
Is it good? Oh, yeah.
Yeah.
Okay. So today we continue to offer this lecture in a hybrid format with both virtual and live audience. Our speaker will present for approximately 40 to 45 minutes, and we'll have 10 to 15 minutes at the end for Q&A. For our virtual audience, throughout the presentation, please use Q&A feature at bottom of your screen to submit your questions. We'll try to answer as many questions as possible during the Q&A session at the end. For our live audience, you will have the chance to ask the questions during Q&A session as well. Okay, today is our great pleasure to welcome Professor Doug Weber here, and Doug Weber, a long-term friend and a former doctoral program manager. I tried to get him to talk for many years, and now he's okay. Doug is a professor in the Department of Biomedical Engineering and Neuroscience at the Carnegie Mellon University. He received his PhD in bioengineering from Arizona State University and completed his postdoc training in the Center of Neuroscience at the University of Alberta. His primary research area is neuroengineering, including studies of motor learning and control of walking and reach, with the emphasis of application to neurotechnology and rehabilitation medicine. Specific research interests include recording and interpreting neural signal to control assistive and prosthetic device and neurostimulation to enhance sensory and motor functions. Okay, the floor is yours. Thank you.
Okay. We have to go into presentation mode. Okay, it's down here, right? And then is sharing on? All right, here we go. All right. Well, thank you, Chi, and welcome everyone. It's really nice to be in person again. I hope you don't mind me not wearing my mask. It's just really hard to lecture through a KN95 mask. So anyways, it's really a great pleasure to be here. And I'm excited to be talking about the work that we're doing in developing neural interface technologies for restoring sensory and motor functions after injury. I'm going to talk today only about the work we're doing in humans, which I'm really excited about, and I hope you'll find exciting as well. Just know that there's behind the scenes a lot of other work going on in animal models, which has really laid the foundation for the work that I'm going to be describing today. So if you have questions that you think are more fundamental in nature and less applied, I'm happy to entertain those as well. So just a couple of disclaimers. We are very focused on translational neurotechnology in the lab, and as a result, we work with a number of neurotech startups, including one that we just created ourselves. So the motivation for our work is really outlined in this slide. There's a number of neurological conditions and injuries that will deprive people of the ability to perform important activities of daily living, whether it be walking or reaching and grasping to manipulate objects in their environment. Things like stroke, spinal cord injury, and amputation create permanent deficits that prevent people from really achieving even the simple goals in their daily life independently. And for these people, there's really not a lot we can offer them. If you suffer a stroke and you have a paralysis that persists for more than 3 months, it's likely that that paralysis will be permanent for the remainder of your life. And again, there's nothing that the field of medicine can offer you at that point. Similarly, with spinal cord injury, there tends to be a short period where some recovery of function is seen in the first few months after injury. But again, once you get outside of that acute window, the likelihood of further recovery of function is extremely limited. So in the absence of curative therapies for these conditions, I feel we have to rely on technology to try to bypass those injuries and provide people with technology that can assist them in performing activities of daily living independently, because that independence is hugely important for quality of life. And I'm somewhat hopeful that we can offer tools that are useful, because we're pretty good at building robots that can now mimic the form and function of biological systems, even as complex as the human arm and hand. The arm that I'm showing you here was developed at Johns Hopkins University Applied Physics Lab with funding from the DARPA Revolutionizing Prosthetics Program. And you can see it, it doesn't have the flesh and bone of a human arm, but it has the dexterity, speed, and strength of sort of the average human arm, right? So we can mimic the basic functions of the human body with machines like dexterous robots. But in order to make those machines useful to a human, we need to couple those sophisticated actions with the human's body, and specifically the nervous system. So that's really kind of the central focus of my work, is how can we take machines that have the promise of restoring function and couple them to a person to enable them to use them effectively. And I'm hopeful that in fact, I'll show that we can do a lot to sort of complete this integration. But it's because we know a lot about the brain and the nervous system, and specifically how information about motor and sensory functions are represented in the brain, spinal cord, and peripheral nerves. That fundamental neuroscience is the knowledge that enables us to build effective connections with the brain. And as well, the technology that we use to measure and stimulate neural activity is what builds the bridge or enables us to form connections with the brain and other parts of the nervous system for establishing communication. Okay, so this talk is really about measuring and stimulating pathways, sensory and motor pathways in the nervous system to extract information or deliver information for restoring sensory and motor functions. So the first half of the talk is going to focus on measuring activity in motor parts of the nervous system. interpreting that activity to infer actions that a person is trying to perform, and then coupling those decoded signals to drive actions in assistive technology. And I'm going to talk about both intracranial or sort of implantable devices and wearable devices in this half of the talk. And then in the second half of the talk, I'm going to focus on interfaces with the sensory part of the nervous system, where the goal is to either restore sensation or leverage those sensory pathways to drive increases in function on the motor circuits. So I did my PhD work with Jiping He and Andy Schwartz at Arizona State University many years ago. And at the time, we were working exclusively in monkey models, trying to understand how information about reaching movement is represented by populations of neurons in motor cortex. And by sampling from enough of those neurons simultaneously, we and others showed that it's possible to make predictions about movement that could ultimately be used to form commands for driving robotic arms. And so Andy moved to University of Pittsburgh in 2002, and shortly after that did work showing monkeys using those brain-derived control signals to, in real time, control the reaching and grasping actions of this robotic arm. And so here the monkey is sitting in a chair. He's being offered marshmallows, which, you know, who doesn't love marshmallows? Monkeys certainly love them. And he's able to reach anywhere in the reachable workspace of the arm to position the end effector at a point that is appropriate to grasp and retrieve the marshmallow. And you can see, you know, we can position the target anywhere, and the monkey is able to generate command signals that drive the arm directly to the target, grasp the marshmallow. And in some cases, he makes a mistake and has to correct, but he has essentially free-form control over the actions of this robot. Okay, so very early proof of concept that it's possible to, in real time, extract information from the brain and couple it to the actions of an assistive device. Okay, and so from there, we set to work building a human BCI program at University of Pittsburgh, where the goal was to use implantable sensor arrays in humans with paralyzing injuries like spinal cord injury to see if we could control assistive devices in humans. And so the first participant for this study was Jan Sherman. She has paralysis, extreme paralysis from the neck down. And so she has quadriplegia. And for, I think when she started the study, she was about 8 years into her diagnosis. And so for nearly a decade has been unable to use her arms and hands. And she volunteered to have a pair of Utah arrays implanted into her primary motor cortex, into the shoulder and hand areas of motor cortex, to allow us to measure signals that may express her intentions to reach and grasp. And so she was essentially taught to control the actions of the robot arm that I showed you at the beginning of the talk, to move around to objects in the workspace, grasp and manipulate them. So I'm just going to show this video now, which I think provides the best example, or a really nice example of what's possible with technology like this.
5 months after the surgery, we came back to see whether she would be able to control.
So that's Jen Collinger. She's the PI on the study.
Her thoughts. They plugged her brain into the computer, and this is what we saw.
Open it up, and straight down, and left to right, diagonally. I can close it and open it, and I can go forward and back.
That is just the most astounding thing I've ever seen. Can we shake hands? No, really.
Yeah.
What? Come right over here.
Yes, you come over there. Press your hand there. There we go.
Oh my goodness. Wow.
And I can do a fist bump if you'd like.
That's amazing.
So I think that the so I love that video, but I think the thing that's most amazing to me is that, well, a couple things. One, this is very effortless for Jan, and it's completely free form. It's not like she's picking from a menu of 8 options of things she could do with the hand. She's doing whatever she wants with the hand and expressing those intentions very clearly. And there's a little bit jerky at times, but it's, again, very effortless for Jan, and she's able to do kind of what she wants at will. And that's, I think, a testament to the ability to measure enough information from the brain at any moment in time and interpret it in a meaningful way to express clear intentions to move. Okay?
5.
But obviously a challenge there is that Jan had to undergo a fairly substantial surgery to have a pair of electrode arrays implanted into her brain, right? Neurosurgeons had to open the scalp, the skull, the dura. The electrodes had to be placed into the brain tissue, which of course is delicate, and we have to be careful of bleeding and other side effects. And then the pedestals, the communication channels, are hardwired through the skin. So there's this permanent plug that has to pass through the skin to give us access to the signals, right? So very promising technology, but still very challenging to implement clinically, okay? Which is one of the reasons we've begun exploring other ways. What other signals might we access to enable people to control assistive devices when paralyzed like this. Okay, and so some work that we started just a few years ago and was recently published in Journal of Neurophysiology is aimed at developing wearable sensor arrays that can measure many of the same types of motor signals that express someone's intent to move, but can be done without having to do any surgery. And so the approach is to take high density electromyography arrays, incorporate them into a garment like a sleeve that can be worn on the arm to measure activity in muscles that are somewhat paralyzed, but still have enough residual neurological function to generate electrical signals that we can measure. And so, this, if we can do this, then we can use motor intentions expressed that way to control the movements of wheelchairs, exoskeletons, and other devices that assist recovery of function. As well, it's a tool that we think could be used to track changes in motor recovery over time. So this work really started with experiments with our BCI subjects. So both of these gentlemen have electrode arrays implanted in their brain and were participating in the BCI experiments. And so they were happy to test drive this sleeve array approach for us. And so the tasks we had them do were sort of impossible tasks. We would show them a prompt on a computer screen that would say, grasp your hand or open your hand or extend your index finger. And while neither of them had any function in their hand, that is, they couldn't move any of their digits, they were still able to follow the instructions, and they gave it their best go at producing movement. And in spite of their inability to actually move their digits, we were surprised to see that there's clear patterns of volitionally modulated myoelectric activity still remaining in the arm in spite of that motor complete injury. Okay, and so to try to mine that activity for information that we might use to interpret action, we decided to use motor unit decomposition to try to pull out the spiking activity that is embedded in the composite EMG signals that we're measuring. So this is a technique that is enabled by the use of high density array recordings, where with an array of myoelectric signals, we can do blind source separation to identify the source spiking activity that is present in the muscles. So we can actually generate spiking signals that are more analogous to the types of recordings that we're getting in the brain, right? Where in the intracranial work that we've done over the years, it's always been with spiking activity recorded with Utah arrays. Here we're recording spikes from motor neurons that reside in the spinal cord. Okay, so motor unit decomposition allows us to do that. And when we apply that to the sleeve array data that we recorded from one of our subjects, we found that there's clear reciprocally spiking activity recorded from a population of neurons that in this case were active during movements of the wrist. So in this case, the subject has some spared function in his wrist. His extensor function is a little bit stronger than his flexor function, but we could see modulated spiking in both directions. That looks great. If we apply non-negative matrix factorization to the firing rates of those units, we can see that there's two clear modules or two clear groups of cells that are reciprocally active. We have our extensor group generating one direction of movement and the flexor group generating the other. So, clear signals indicating intention to move. And maybe not surprising for a joint that has some spared function. The index finger, on the other hand, in this subject was completely paralyzed. So asking him to extend and flex any of his fingers didn't result in any action, but it did produce somewhat modulated spiking activity in the array. And it's much harder to see than in the case of the wrist joint. But again, using non-negative matrix factorization, we do see that there is reciprocal activity that corresponds to the attempted extension and attempted flexion movements of the joint. It's weaker, but that's, again, not surprising. He is completely paralyzed, and he has no feedback that's telling him, yes, your index finger is extending, or yes, it's flexing. This is all just sort of wishful thinking on his part, trying to get the joints to move. But in spite of that, we see the emergence of what we are confident is voluntary control. So one additional test we can do to verify that, in fact, yes, he is following the prompts that we're giving him. If we apply a Fourier transform to the firing rate data, we see that in fact there are clear spikes in the signal power at the movement frequency that we're using to cue the subjects, and that is also true for the index finger, where it's less clear that they're actually voluntarily modulating the firing rates, but the PSTs show that pretty clearly. So another test for information that's embedded in this in these signals is to look at the population activity and test whether or not it's task discriminant across all of the different gestures we ask the subjects to perform. So in this case, I'm just showing you the single digit gestures that we ask the subjects to perform. And we use principal components analysis to take that large array of signals and compress it down into a 3D space that's easy to visualize. And what you see is that if you try to separate the clouds of activity that represent firing rates during different discrete gestures, for the motor unit activity that we analyzed across digits, there's very clear separation for each of the 5-digit movements. That is less clear when we're using an EMG power signal. So the point here is that having access to that spiking activity is really valuable when trying to discriminate different actions in these recorded signals. So the raw signals are identical in these two cases. The only difference is the steps that we took to extract features from those raw signals and classify them. And again, spiking activity is much better for that. And then the final test is to actually apply classification analyses to this to see how accurately can we discriminate attempted movements from these recorded EMG signals. And again, looking at the diagonals along these confusion matrices, using motor unit spiking activity, we can classify attempted movements much more clearly. And there's far less confusion across digits as well. Okay, so the first half was really focused on what can we measure from the body to tell us what people are trying to do. A real important point to note in thinking about building interfaces like this is that simply measuring motor intent is often not enough, because often the motor output that we're measuring is conditioned heavily on sensory input that needs to be available to support that motor output. That is, we are very dependent on our sensory systems when shaping our motor actions. And oftentimes, in the case of BCI applications, the only feedback that is available is visual feedback, whereas most of our motor actions depend critically on somatosensory input from our skin and muscles. And so we are very focused on ways we can provide sensory feedback, specifically somatosensory feedback, to use that to support motor function in these BCI contexts. We tend to focus primarily on lower level access points in the sensory hierarchy, peripheral nerve, spinal cord, and dorsal ganglion. And here I'll just talk about the work we're doing in humans using a technique called spinal cord stimulation, which is used commonly in the clinic to treat pain. And it involves electrode arrays that are tunneled in the epidural space of the spinal canal to deliver electrical stimulation to the dorsal surface of the cord. Normally, the electrodes are placed kind of right along the midline of the cord to target the ascending fiber tracts. In our applications, we're shifting the position of the electrodes just a little bit laterally to try to target not the projections in the spinal cord, but the incoming fibers from the dorsal roots. These are the primary afferent neurons that carry the touch and movement sensory feedback signals that we want to promote. Okay, and so working with my colleague Lee Fisher, we've been working now for a few years to use these epidural spinal cord stimulation electrodes to target these primary afferent pathways at their entry point into the spinal cord, and using that technique in lower limb amputees to try to restore sensation and promote movement in the amputated limb. Okay, and so we know, based on anatomy, what levels of the spinal cord to target to promote sensation in different parts of the lower extremity. So the physicians that place the electrodes have clear access points to try to target. This is what the leads look like on an X-ray after placement. So there's usually a pair. Sometimes we use 3 arrays of 16 electrodes that give us, many sites to try to activate sensory pathways associated with the amputated limb. Oh, and our approvals allow us to implant these devices for now up to 90 days, since we have approval from the FDA for a long testing period. To date, we've only done testing in the lab, but in the next phase of our project, people are going to be going home with devices and actually using them in their activities of daily living. So here's just some maps of what our patients or what our subjects describe when we stimulate at various locations along those electrode arrays. So we give them just a silhouette of the legs, and they have to draw on a tablet where on their body they're feeling sensations when we stimulate. We're looking specifically for sensations that are referred to the missing limb or below the level of amputation, which is shown here by this red dotted line. And then using those sites to try to stimulate to restore sensation to their missing body part. And again, across different subjects, we see a kind of a wide variety of sensations that are produced. In some cases, the sensations are very focal. In other cases, they span large areas. It really depends on where the electrode is positioned relative to the underlying peripheral nerve anatomy. Okay, and one of the things that we had hoped might be beneficial with this approach is in treating or reducing sensations of phantom limb pain. Phantom limb pain is something that's really common in people with amputations. I think roughly 70% of people experience this. And it seems to be a phenomena that is ironically caused by the loss of sensory input to the nervous system. And so when you lose a body part, your brain and maybe spinal cord, in trying to recover from that loss of sensory input, creates this illusion of sensation from that missing body part, which in many cases becomes painful. And we're not the only ones that have observed this phenomena, but it seems that in attempting to restore sensory input to that missing body part, the occurrence and severity of phantom limb pain seems to diminish to the point where, if you test for a couple of weeks and then pause testing, the phantoms sort of come back, in those periods of downtime. So again, it sort of supports this idea that it's the loss of sensation that creates the phantom. And if you restore sensation, even if it's unnatural, because none of the sensations we provide with electrical stimulation are truly natural, but it's sensation nonetheless. So very positive and exciting effects of stimulation in reducing phantom limb pain. We're also interested in understanding and leveraging the effects that stimulation has on improving gait and balance stability. So we're doing tests to look at that as well. One of the tests that we use is called the narrow beam walking test, where essentially we're looking at how stable is the gait. And we test that by having subjects walk on a balance beam that gets progressively narrower, so becoming progressively more challenging as they progress along the platform. And so these videos here show testing that was done. I don't know if I can play this at the same time. I guess I can. So on the left, this subject is walking without stimulation. On the right, she's walking with stimulation, and stimulation is triggered by a switch that's worn in her insole. I can play this one more time. And so she receives stimulation when her foot is on the ground. That helps her improve her stability and specifically lateral stability when she's walking. And so as a result, she's able to get much further along on this narrow beam walking test. Okay. Now, so obviously there are many ways that restoring sensation can improve motor functions and specifically gait and balance stability. Just being more aware of where the limb is in space is a direct benefit. But especially for the lower limbs, the motor output that is driving muscles depends heavily on sensory input that is coming from muscle afferent neurons. So as I'm standing here right now, roughly 60% of the muscle activity that is being generated in my extensor muscles is not being driven by my brain, but by the reflex pathways in my spinal cord that are integrating input from the extensor muscle afferents and reinforcing outputs to the motor neurons. So the point is that stimulating sensory pathways can and does have a direct effect on motor output to the legs, and we want to understand what effects how those effects appear in someone with an amputation. So Dev Sarma is the postdoc on this study, and he's using EMG to measure and map responses evoked in muscles of both the intact and amputated leg when we stimulate the dorsal surface of the spinal cord. And one of the tests that we use to verify that we are, in fact, reflexively activating motor neurons versus directly activating motor neurons is we use essentially a paired pulse test where we look at post-activation depression of motor output in response to a rapid succession of two stimulus applied to the spinal cord. So when we apply one stimulus, we see a nice evoked pattern of EMG in the muscles of the leg. That motor neuron, that synapse between the afferent and the motor neuron becomes inhibited for a period of time such that the second pulse, when the second pulse arrives within 100 milliseconds after that, that synapse is inhibited and the motor response is almost non-existent. So this shows us that, in fact, we are reflexively activating the muscles and that we are having direct effects on muscle activity. And so if we can map the activity that is produced in the muscles of the leg across all of the levels of stimulation that we're providing, And when we do so, what we see is that the map of motor output that is produced matches approximately the map of the motor neuron pools that are well known in the spinal cord. So as we go from rostral to caudal in the spinal cord, the location of motor neurons that we're activating moves progressively from proximal to distal, as we would expect. Okay, so here, what we're seeing is that we can restore sensation, or we can produce, I think, useful sensations that are referred to an amputated part of the body. We can do that in the context of locomotion to hopefully improve the person's awareness or the subject's awareness of where their limbs are in space. But one of the things we need to be mindful of is that there is the possibility of directly recruiting muscle activity that, in the best case would be beneficial and would support their ability to ambulate. But there is also the risk that we may activate muscles that could disrupt their gait as well. So that's why it's important that we understand what effects stimulation has on motor output. And then finally, again, knowing that stimulating sensory pathways can have direct and in many cases positive effects on motor output, we recently started a new project to use spinal cord stimulation to increase motor output in people with chronic hemiparesis after stroke. So stroke, as I said, is can be a very disabling injury. It affects a lot of people, and in many, many cases, the deficits that are produced by the stroke are permanent, and people cannot recover from them. And for those people, there's little to offer in the way of restorative therapies. And so those permanent deficits that don't respond to occupational therapy or any other things are the types of deficits that we are trying to correct or minimize using spinal cord stimulation. So this is a project with Marco Capogrosso, who just joined our group about 2 years ago. And what we're doing is we're placing pairs of these spinal cord stimulation arrays now in the cervical spine of humans, and targeting the afferent inputs to the major muscle groups of the upper arm and forearm, such that we can improve function at the shoulder, elbow, wrist, and hand. And so we did our first patient this past summer. So thankfully there was a break in COVID restrictions last summer, and we recruited our first subject. This was a woman that was almost a decade out from her stroke. And so for over 9 years, she was really unable to use her left hand. She could move her arm a little bit, but it was very slow, very uncoordinated, and her hand was just sort of there, but not necessarily functional, and that she had a hard time opening it to grasp objects. She had a little bit of spasticity, which was frankly a concern for us, because spasticity is often associated with hyperreflexia. And so, since we're essentially stimulating reflex pathways to try to produce movement, there was some concern that we would only exacerbate her spasticity. But I'll show you in a second that in fact wasn't a problem. And so I've already described the implants of the leads. So this X-ray shows where the leads were placed. So you can see they go quite high as the third cervical vertebrae in this subject, and stretching all the way down to T1. And so at stimulation across those levels produces activation in muscles from the shoulder to the hand. Okay, and so again, we do, the first thing we always do in these experiments is we try to map which muscles respond to stimulation at different levels. We need to know that input-output relationship, especially in this case, because the immediate goal is to activate muscles associated with functional movements. And so again, we stimulate across different levels in the array from rostral to caudal, and we find which of the muscles are responding. Just want to acknowledge the people doing this work. Mark Powell is a postdoc with Marco, and Nikhil Verma is a graduate student in my lab. They're the ones doing a lot of this work. And so now I just want to show a couple of videos, again, from this first subject. And what I think is most exciting about this video is this is on the first day of stimulation. So she had the implant surgery done 2 days prior to this testing. And we were, I don't want to say shocked, but very pleased to see that immediately with the onset of stimulation, she's able to see benefits. And so here she's trying to open her hand. And it's very, very difficult for her to do. And so stimulation's off. Now we're going to turn stimulation on. And, you know, for the first time in a decade, she's actually able to open her hand fully. And this brought her to tears, and it brought everybody in the rooms to tears as well, because for her, I mean, it's just a simple thing, right? Like you just opening your hand. But think about it, you know, think about being unable to open your hand and how that would impact your ability to, you know, to do activities. So with stimulation on, this is another important point. With stimulation on, she can open her hand like she couldn't before, and she's still able to close her hand, even though stimulation is on. So that's one of the, I think, important advantages of targeting reflex circuits versus directly targeting muscles. If we were directly stimulating the muscles, it would be very difficult to override that muscle activity, right? Because the muscles are going to be contracting no matter what. But in the case of reflexive activation of these muscles, the voluntary function can override the reflexive function such that the two can coexist synergistically. All right, so that's that. So here, in addition to gains in function at the hand, she also saw important improvements in her shoulder function as well. So here she's trying to elevate her arm above her head. Very important if you want to put on a shirt in the morning. And so she can do it. It's a challenge. It's not very coordinated, but you turn on stimulation and she's able to move much more quickly, much more fluidly. And again, it's just boosting her voluntary autonomous control over those muscles. And then lastly, so in addition to improving strength at those two joints, it's also important that we preserve dexterity and the ability to coordinate actions across joints. And so here on the left, she's just doing a simple touch your nose task. And with stimulation on, her arm is much more sort of nimble and easy to control than on the left, where the actions require a lot of effort and are largely uncoordinated. Okay, and then just to show some clinical scores, so Fugl-Meyer, the upper extremity scale of the Fugl-Meyer is used to assess function. We assess function in two sort of modes. One is with no stimulation turned on. Those are the data points shown in blue. And so at baseline, prior to any stimulation, her Fugl-Meyer score was 36. At the start of testing, or at the week 2 time point without stimulation, the Fugl-Meyer was unchanged. Without stimulation, when stimulation is on, the gain in Fugl-Meyer is 13, which is a huge increase for someone with this level of impairment. And what was really exciting is that at the end of this 30-day period, when we turned stimulation off, her gain in function was preserved. So this was a little bit unexpected given the very short period of testing, but this shows that there's some recovery happening as a result of this SES-assisted movement. And of course, you know, with stimulation on, the gains in function are even higher. This is another bit of a kind of surprising result. As I mentioned, we were a little bit concerned that stimulation would exacerbate spasticity because of the direct effects on reflex pathways. But in fact, we really saw essentially no change in spasticity over the 4-week period. So that's encouraging as well. Okay, so just to quickly summarize, there's really, I think, some exciting opportunities to measure and stimulate sensory and motor functions in the nervous system using both implantable and wearable technologies. there's really a ton of work going on now to develop, especially wearable systems for measuring and modulating activity. I think there's people here working on transcranial focused ultrasound, right? That's a very exciting new therapy for doing neuromodulation non-invasively. But on the implantable side, I think there's still a lot of advantages to using implantable devices, and the emergence of minimally invasive injectable devices such as the Stentrode, I think are really going to change what's possible and really kind of lower the barrier to entry for a lot of these technologies. And then stimulation and recording from the nervous system provides really, I think, life-changing improvements in function for people with disabilities that would otherwise be permanent. So with that, I want to acknowledge the lab. This is us having a party last summer. Before I open the floor to questions, I just want to promote a new program that we started at CMU and University of Pittsburgh to promote or increase representation of underrepresented minorities at the PhD level. And so the approach is to recruit students to our master's program, provide them full funding to help them prepare for entry into PhD programs where they will hopefully thrive. We're focusing on a couple of key areas: artificial intelligence, robotics, autonomous systems, and neural engineering. And the program is open to US citizens and permanent residents. So if you know of undergraduate students that are sort of on the fence, like, hey, your research sounds kind of cool, but I don't know, getting a PhD, that seems expensive, and it seems like it'll take a lot of time. Maybe have them reach out to us, because this program is really aimed at sort of getting people over the fence and into graduate research, where we know that there are lots of opportunities. And with that, I will thank you for your time and take any questions.
Before the Q&A, just need to read.
Okay.
What do you got?
Yeah, this one.
Thank you, Don. Thanks for a fantastic talk. And before we get to questions, I want to call everybody's attention. So next week, we'll have Professor Michelle Harman from Northwestern University. So we'll be the same virtual and hybrid form. Okay, well, so now we are open for questions.
Okay, so for in-room questions, I'm going to try to use this microphone.
Okay. Should I use that and not this? So
Yeah, you
get
could.
feedback on this one. Okay.
Good catch.
Hello, thank you so much for giving this presentation. I was just wondering if your lab had encountered anybody with diabetic amputation, just because it is the leading cause of lower limb amputation in the United States, and what the implications of oftentimes these people have neuropathy as well, and how that affects the electrodes that you are putting in the spine.
So that's an excellent question, and I can say that the vast majority of participants we've tested, have amputations because of diabetic neuropathy. It does affect their sensory fibers, as you've noted, but that degeneration process moves distal to proximally, and so because we're at the most central part of the primary afferent, we're okay for now. I think it's an open question as to how long is before those fibers become too degenerated to be responsive to stimulation. But yeah, it's an excellent question.
Thank you so much.
Pass back to her.
Yeah.
Thanks so much for this great talk. It was really, really fascinating. And I think as you're going through the presentation, there's always something I was like, oh, I wonder if the technology will go here next, and then you click to the next slide and it's already done.
Awesome.
So,
I wouldn't say anything is done right now, but there's a lot of promise.
yeah, I was really blown away by the extent of the applications that you've been able to cover this work. One thing that I was kind of wondering overarchingly is what is the overall psychological response of patients when they hear about these things? Do you have people who are freaked out and end up not wanting to participate in the trial? I'm sure there's also a lot of joy and just amazing comments that people have unexpected sensations, physical sensations, or emotional reactions. How do people respond to like this technology? What does it mean for adapting?
Another really, really good question. The psychological responses have been strong, but not entirely unanticipated. And especially for the implant studies, we actually do a screening, to make sure that people are psychologically prepared for the experience. And I think that's probably important. But then, for the people that gain entry into this study, it can be very emotional. I mentioned that the woman that was the first in our stroke study, I mean, she was brought to tears, like literally on day one, and, by the end of the study, she's like, wait, you have to take it out? I want it back, because again, we don't yet have a product to offer to the participants. So we recruit them with the promise that, hey, this work is only going to help people in the future, create technology that people in the future will access. But it's really hard for them to, sort of come in, see this benefit, get a lot of hope, and then have to sort of lose it, I guess. But one of the companies I put on the first list is Reach Neuro, and so we're hoping that within 2 years we're actually going to have a product. It won't be a product at that point, but it'll be a permanent implant that that people will be able to access through an early feasibility study. So yeah, but it's a challenge, right? Because it's like, ethically, is it okay to bring people in, do this research, and then have to sort of take away something that they found beneficial? But I think it's okay as long as we keep working on actually providing a permanent solution.
I'm going to take one question from the online audience, and then I'll get to you. One question online was, is there pain associated with the simulation?
There can be. And so every stimulation experiment begins with kind of some range finding and some mapping, right? We find which muscles respond to stimulation at a given location. What is the range of stimulation parameters that are effective? Where's the threshold for producing muscle activation? That's almost always lower than the threshold for causing pain. But usually we don't get near the pain threshold. It's just not necessary. But it's certainly a real possibility.
Hi, I just briefly want to echo what everyone's been saying. Thank you again for being here. It's very fascinating.
Pleasure.
I'm wondering, so you talk a lot about the interface between the brain and then the actuator, the computer and such, but I'm wondering how you see the mechanical limb itself kind of evolving. You guys work with soft robotics, kind of what's your take on it?
So there's a huge group at CMU focused on soft robotics. And for 15 years, I was at University of Pittsburgh and almost focused entirely on the neuroscience end of things. Moving to CMU has put me in much closer proximity to the robotics folks. And so, yes, that is one of the things we're working to do, is because that's a key part of the system as well, right? We're sort of taking it for granted that it's just a robot, right? You can buy those anywhere, but no, there's a lot of work that is still needed to make those systems truly compatible biomechanically with people.
Thank you.
I'm going to take one more question from the online audience. David Lillyman asked, can you speculate on potential future use of implants like these to modulate pain? Would it be possible to interfere with nociceptive signal transduction at the level of the DRG or spinal roots?
So the short answer is there already exist two broad classes of devices for treating pain using spinal cord stimulation and DRG stimulation. And from a hardware standpoint, the devices look very similar. Functionally, they both deliver electrical stimulation that interferes with either the transmission or processing of pain from primary afferents in the spinal cord. DRG stimulation is thought, well, one of the theories for DRG stimulation is that by stimulating at the site where the cell bodies for the primary afferents are located, you can shut down transmission past the T junction, which is the point where the axons intersect with the stem that is connected to the soma. And so exciting the cell there blocks that propagation from in C fiber pathways, the nociceptive fiber pathways. So that's I think one example of how the electrical stimulation can modulate, like shut down transmission of pain. And then spinal cord stimulation is thought to work in a slightly different way, where rather than blocking transmission, rather than blocking propagation of fibers along the primary afferent, spinal cord stimulation is thought to activate the gating of signals in the spinal cord, where you're activating a primary afferent pathway that is synapsing on a downstream part of the circuit to block the transmission of the nociceptive signal. So one is transsynaptic and one is direct.
I just wanted to say thank you again for a really fascinating talk. I was wondering if you had experienced any limitations in like resolution based on the density and distance between your electrode arrays and how that could be overcome.
You're talking about spinal cord
Yeah.
stimulation?
Yeah.
Absolutely. Right now we are, for the human work, we are restricted to using devices that are approved for use in humans for good reason, right? There is some hope that we could design better electrode arrays that are more precise in activating a smaller set of fibers so we don't produce such widespread activation. There are trade-offs to doing that because the more complex the technology, the less likely it is to work in the clinic. And so, do I think that a high density electrode array will offer better function? Yes. Do I think it's clinically viable? Maybe not yet.
Thank you. Yeah, so I guess a lot of people are probably very excited about your research. And one thing for us really interested in translating our research into human is FDA approval, right? So can you share with us your experience, especially for the one with the stroke, the implantation for the stroke?
So we haven't yet filed an IDE for the stroke work. That work is approved by the local IRB. Because we're just using FDA approved devices in sort of a trialing mode, right, where the wires are routed percutaneously. So we're hoping to go to the permanent implant stage in the next year. Honestly, the FDA has been extremely supportive of this work, and I think in large part because of the BRAIN initiative. They have been directly engaged with the research community. If you go to a neural engineering meeting, or if you've gone to, well, nobody's been to meetings in 2 years, but before the pandemic, when we were getting together at meetings, there was always strong representation from the FDA at those meetings. Like, they are very supportive of innovations in the neurotechnology space. They've created this breakthrough device designation to help sort of facilitate translation. They're not going to cut any corners, right? That's not what they're trying to do. They're just trying to work proactively with the community to make sure we know what is necessary and we have the guidance that we need to get through the process. But when I was at Pitt and still work closely with them now, there's 4 IDEs for different studies that are approved in just that one lab. And again, it's all in direct collaboration or in close collaboration with people at the FDA. So it's daunting, it's a lot of paperwork, but it's not like they're trying to be a barrier to progress. They have to make sure that we do things safely, and they help us through it. So thank you.
I think we have time for maybe one more question. There's a question online, how do you deal with the immune responses associated with the implanted BCIs? And I had a related question just in general about long-term safety of these things.
Yeah, so that's a good question. And for many, many years, and frankly, really before the human human intracranial BCI programs took off, there was, I think, greater concern that that implant stability would be a limiting factor. But now our group and many other groups have shown data from humans that's exceeds 5 years, where you don't see the exact same signal every day. There's some variability in the recording quality and stability, but the signals are still usable for those very long time scales. So it's a problem that we still don't fully understand, but it's also one that I, for one, am less concerned about. Now that we have all this data in humans that shows that for 5-7 years out, we can still get good control. Signals are again very clear. So
Does something happen after 5 years, or is it more just that's as long as the data goes?
that's just as
So it might go for a long time.
It might, yeah. I don't know if there's any. I'm not sure if anyone has hit the 10-year mark yet. Interestingly, the reasons for explant are often unrelated to the actual signal quality, like the skin around the percutaneous pedestal can start to recede. And so, you can't have open, exposed skull. So at that point, you just have to make a decision. But that problem goes away if you have an implanted telemetry system and so on.
Okay, I think we'll wrap up there. Doug, thank you so much. This is wonderful. Thank you.